Hello. Decided to change it up and not say "Hey guys" this time. This video is on nurse provider rounding, a little more emphasis on that, and I wanted to tie in the initial huddle with this. Remember, the initial huddle with the charge nurse from 6 to 8 a.m., we were going to help the charge nurse kind of prioritize how we want to see folks. So our first call for nurse provider rounding would be to the charge nurse to say, I want to see cohort A with this early discharge, or remember we had that patient that was not doing well, that may be also involved in a cohort that you want to see early. So you identify whoever it is that you want to see early, that cohort of patients, so that the charge nurse then concomitantly calls the shift primary nurse to arrange that first cohort of patients to be seen by that primary nurse, so she'll get that primary nurse in the room with us. So the first call is to the charge nurse to identify who you want to see first. Remember, there's a little leniency in how you want to round, as mentioned in the first video. I won't go back to that. So as we go to the room, the group that will be there will be the charge nurse, shift primary nurse, and provider. Remember, the shift primary nurse and the provider are the two that are doing the most interacting. The charge nurse is there kind of as a kind of an air traffic controller, for lack of a better term, or to help the shift primary nurse be available for that. Now, there may be times where the shift primary nurse may be occupied and the charge nurse slips into this role, but the role will stay the same. So the first step, and as you come in the room, knock on the door, introduce everybody's role in the care of the patient. And the provider's job is then to pull up the visual management tool, which each of you should have access to, and I'll try to be sure that we have that. In the visual management tool, as you look through it, on the left-hand side, you will see a couple of things. You will see length of stay, GMLOS, and medical necessity. These are all the first part of this process to get in our mind if this patient is on track, to leave the hospital in an appropriate time. Now, keep in mind that some folks do go over length of stay, or LOS goes over GMLOS, but they still meet medical necessity. That person, we're not asking you to go against clinical judgment on that, but this is just to kind of keep us all in mind of where the patient is along the hospital stay. Those that aren't meeting medical necessity, is there something else we need to document? Do we need to document something different to, if they're still needing to stay in the hospital clinically? That may be an opportunity for us to change the documentation to appropriately reflect why they're in the hospital, etc. So first step, pull up visual management tool after the introduction, get an idea of length of stay, GMLOS, and medical necessity, so that can be in our minds. The other purpose of that, once you see the visual management tool, is to click into that patient's chart so that you can be on the order screen. I'll get to that in a second. So we're on the order screen, and after this point is where the nurse will then begin his or her communication with you and the patient. Keep in mind that we want the patient to be involved in this. So you will see some laminated cards that you can get on B1 West. It kind of talks about pertinent clinical events or pertinent clinical things to the patient's hospital care and throughput that the nurse will go over. Certain things like significant events, or Foley catheter, or bowel movement, or restraints. DVT prophylaxis is on there. Also things about blood sugar checks or current antibiotics. So you can go through that list, but it's also our opportunity as a team to be sure that we discuss these things. So if the nurse didn't mention something that you may want to know, this is your opportunity to ask them about it. And kind of both teams as a team coach in that moment. After the nurse, and this should take roughly about a minute, it shouldn't be a long conversation that occurs, then we shift over to the provider. And let's keep in mind that the provider then goes through a brief exam, and then we talk about the diagnoses that the patient has. And I should say that we want this total interaction in the room to be roughly between 5 and 8 minutes. Because keep in mind, the nurse has other things to do, and we want to be respectful of their time, but also you have to kind of get through your day to see the other patients as well. And there may be times where we have to cut our provider / patient communication a little short and ensure that we come back to them later if they have further questions. So the provider at bedside has an opportunity at this point to examine the patient, go through the diagnosis, and then go through their goals of the day. What do we want that patient to achieve that day in the hospital to move them along their hospital stay? There may be things like getting up and mobilizing. There may be things like, let's see, improving nutrition. So as we establish these goals of the day, some of these will be entered as orders: discontinuation of IV fluids, maybe change of antibiotics to oral. Those are things that we can quickly, with the orders tab pulled up, just place in the chart while we're at the bedside. Concomitantly, the nurse will then be writing these goals of the day on the board, and maybe 2 or 3 things that we want them to achieve during the day. And the final thing in that interaction between the provider, the patient at the bedside would be to ask the patient, what are their goals of the day? One of their goals may be to leave the hospital. That may be possible, may not be possible, but how can we move them along that state to then reach their goal, and communicate with them verbally that. And the other thing that's important and that we want to emphasize and get on this whiteboard with the nurse is potential discharge timing, meaning what's the date? Maybe it's tomorrow, maybe it's 72 hours from now. But to get a goal down, and then doesn't mean that we have to always hit that, but it means that we're kind of always thinking about that so that the patient's not surprised, and get that date written down. If it is somebody that's going home tomorrow, is that somebody that we can potentially start preparing for an early discharge? So somebody that could discharge before 9:30, can they get their ride there? Identify, you, the nurse, and the patient, identify things that they need for home so that you can then write those down for case management. So remember, we talked about goals of the day being in 2 categories: things that we can enter directly into the orders, discontinuation of IV fluids, decreasing steroids, stuff like that we can do real time. Other goals of the day may be we need to write down for the nurse. So the nurse may have one of her goals of the day being a room air sat to prepare for the potential of oxygen tomorrow. So you would write that down on a sticky note, and we'll keep those with us on these rounds. The other potential goals of the day may be for case management. It may be that you and the nurse have now identified somebody that needs to go to a skilled facility. So it may be that we need to fax out or get case management to help us, or kind of hold them accountable to getting that next piece done for the fax out to potentially get them to a skilled facility. So that would be something that you would write down. These goals that are written down, we need to get them back to the IDT board, and I would leave that kind of for the staff to kind of help us with. So that's the quick interaction at bedside. And again, we want that to be, that part, the provider part, maybe 3 to 4 minutes. So you're working on about 5 minutes total there, and that leaves you a little bit of extra time as well. But as we want to then thank the patient for letting us come see him, and then we leave the room, and outside the room we want to have a quick debrief, any kind of things that weren't written down, or maybe something that you weren't able to order. Just identify who's responsible for getting that done, and then we can get those things back to the IDT board, which will be another part of this process later in the afternoon. So in short, nurse provider rounding is meant to be a 5 to 8 minute conversation, nurse, charge nurse, and patient, to have an interaction to get on the same page with communication for the day. And again, let's just keep in mind that we want to be mindful of everybody's time in there, and it may be that you have to kind of excuse yourself and say, Ms. Smith, I know that it's important for you to have these questions answered. I'm going to have a little bit of time after lunch where we can sit down and talk a little bit more about some of these questions that you have, but I want to be sure we get your plan going for today, so that we can get you better as soon as possible. But I need to come back at a different time so that I can spend all the time that you would like for me to there. So may have to figure out a way that however you want to word that for the patient to keep that timing respectful of everybody that's involved. So after the debrief, then nurse provider rounding is complete, and I'll go to IDT next.